in just a moment.
Good morning. Such a busy time of year as we're also straddling vacations. Good morning, Jonathan. Looks like you're somewhere nice. If everyone can take a chance, a moment to put your name in the chat, introduce yourself. You know, we have some new folks. That'd be great. Use it as a way to network as well. Terrific. Robbie, should we get started?
Yeah, let's do it.
All right. Hi, everyone. Welcome to Connecting for Better Health, our July edition. You'll note that we just canceled our next meeting in July, taking a bit of a summer break. We'll be back in August. We have a really packed agenda, and our guest speaker, Dr. Lynettes Scott, is with us from DHCS. And you'll notice on the agenda that we're actually going to move her up to the top so that we have ample time for questions. And so we're really looking forward to that discussion. Just as a brief preview, I had the opportunity to be in the audience when Lynettes presented a few months ago to the California Association of Health Plans, and was so blown away by the content and the message. We reached out and we're able to get her scheduled here today, so it's a real treat. We also have updates on the data sharing framework that we will relay. Lots of great work, new updates to the policies and procedures that you should know about. Our federal updates that we are tracking on the info blocking, also very germane to our work. And then lots of policy updates. And for those of you that, I think I see several of you that were on the call with us yesterday, tracking the Senate Bill 1331 that represented a lot of the work that you all contributed to. Not a spoiler alert, but passed the Senate yesterday. So health. So we are, we'll have an update there too. And then finally, you know, feel free to also use the chat for your news and announcements. We'll also make sure that you have in your agenda some things that we're tracking. So with that, I think we'll just go right directly, if we can, Robbie, to Lynettes' presentation. And Lynette, are you driving or are we?
Yes, I think, Lynette, we were going to let you drive if you wanted to.
Okay, I can figure out how to do that.
And Robbie, can we record this today?
Yes, and it's already being recorded.
It's already, okay, I just didn't even notice it while I was speaking. So yeah, Lynette, just a brief overview of the work that Lynette does. We've been fans of her work for, I don't know, Lynette, how long has it been? Over 10 years?
Yeah, oh yeah, over a decade.
Over a decade. And you know, we've been working with you to be able to get us into this landing zone of where we are with health information exchange throughout the state, and also on the levers that you're able to pull within Medicaid and within Medi-Cal. So that's what we'll hear about today.
Great. And let me just do a double check that what you're seeing is the presentation screen.
Yep.
Yes, we can see it. This looks great.
Anything extra? Okay, fantastic.
Great. Thank you.
I'm always excited when I get it to work right. Well, thank you so much for the chance to talk with you all today. Hopefully this is not too much of a repeat. Some of you may have heard some of this information before, but if so, hopefully you'll get a chance to hear something a little bit different. So there's a lot going on, as you all are very well aware. And we get lots of questions about how the different pieces fit together. So part of the goal with this presentation was to try to help draw some of those connections and to help folks see how these pieces do support each other and where the synergy is. So this is sort of my picture view of an agenda slide, and we'll dive into more detail on, in particular, the blue items. So I'll kind of hold on that a little bit. On the orange items, the California Data Exchange Framework and HCI's healthcare payments data base. Those two pieces are distinctly outside of DHCS. So the data exchange framework, I think you all are probably tracking very closely, includes requirements for our Medi-Cal plans and providers and various entities that are part of our program. But it is run by CDII, so it is distinctly separate and it has its own requirements. Although the requirements of the data exchange framework are synergistic with our interoperability requirements, which are on the far left. And so trying to make sure as we move through all of this that we're not creating conflict, but we're creating synergy. So we do work very closely with John Ohanian and his team to make sure we're lining up those components. And then HCI with the Healthcare Payments Database, essentially our all-payer claims database here in California, we do transmit all of our Medi-Cal data to HCI for that. So it includes that. One of the questions we've received over the last year or so was, well, will DHCS send the Medi-Cal managed care plan data for them to the exchange? And this is where this confusion kicks in, right? So yes, we are sending our Medi-Cal managed care plan data to HCI for the Healthcare Payments Database, which is our all-payer claims database. We do not send our Medi-Cal managed care data to the data exchange framework, which is data exchange. It's not a database. It's not a thing, right? It's an activity. Part of including that here is to have the chance to sort of help distinguish between these things. So again, HCI with the healthcare payments database is an endpoint around being able to do policy analytics. Again, that all payer view. We are providing federal funds to them as part of our Medicaid enterprise system to help support that, because some of our reporting requirements under CMS include being able to compare Medi-Cal to non-Medi-Cal. And so having that more holistic view is super important. And so we do send data and money both to that effort and partner with HCI on that. Again, distinct from the data exchange framework, which gives us all an opportunity to be able to participate in data exchange to support care delivery, coordination, and improved outcomes. So that's those two pieces. So then over the next several slides, we'll dive into the blue circles, which kind of helps tie all these pieces together that are specifically under DHCS. Let's see. So starting first with high tech, it is technically over, but it really laid the basis and created the environment for us to do all the things we're doing today. We could not do the data exchange framework in the way that we're doing it if we did not first have high tech. So high tech, again, I think many of you have been very closely involved in this, really taking us from paper to electronic in the healthcare world. Just really reminding folks that we put a lot of money into this here in California and brought in a lot of federal funds. So the agency received $38.8 million grant related to health information exchange. And then at DHCS, through the EHR incentive program, which got renamed to Promoting Interoperability Program, we were able to bring in over $1.6 billion of federal funds, 100% federal funds, to over 25,000 providers and 330 hospitals so that they could adopt electronic health records and begin to use those. So high tech very much has formed a basis of where we are today, and we're building on that. So CMS very much has said, great, we put out billions of dollars, we've seen the healthcare industry start to transform, but we're still hearing that there's a problem with actual exchange occurring, right? So this idea of interoperability and making sure data is actually moving still has a lot of challenges across the country. And so even though high tech has ended, CMS has said, well, we still want to drive this forward. We're going to use our regulatory power to, again, put in requirements that will apply to Medicare, Medicaids, and the health benefit exchanges in terms of the federal benefit exchange to really try to get to the that true goal of high tech, which was not just to have an EHR, but to actually have data that's electronic, that moves with patients, that gets to where it needs to be, without folks having to get a CD or a printout or an email and then walking it over to their next provider that they're going to see. So 2020, right after we shut everything down for COVID, CMS issued the CMS Interoperability and Patient Access Rule. Again, it set forward some very specific requirements around how we're going to move data, so FHIR APIs. And this rule particularly focused on the idea of some of the provider information and then the patient access API. So being able to have that API in place so a third-party application can come and connect and then provide data to patients. The rule also included payer-to-payer data exchange for our managed care plans, but CMS did back off on that and say, we're going to use our discretionary authority and not enforce that. We'll provide more detail in the next follow-on rule, which we all saw come out in December 2022 as an updated proposed rule, the CMS Advancing Interoperability and Improving Prior Authorization Processes. So in that context, lots of comments got submitted to CMS. They're working on processing those. We'll see what the final rule and the final timelines look like. But certainly a theme that we're seeing across all of these is FHIR APIs is the infrastructure that we all need to have. And so that feeds into our conversations around data exchange framework here in California. And that CMS is going to continue to push forward in terms of having regulation that they can then hold us all accountable to make sure that we don't just have our EHRs, but we're actually moving data in a way that has got standards so that we can provide high quality care to our patients and our members. And they're not having to transport things around manually. We don't want to continue to hear stories of people with the 10-inch paper charts that they have to carry the boxes worth in their trunk right when they're getting care delivered. So very much want to see this push forward. And of course, the other part too that is a key theme, I think, of the interoperability rules is how do we reduce burden on the health system and on providers. So this piece around prior authorization is, again, a significant pain point that we hear lots of folks talk about in terms of both the workload in doing prior authorization and then also the burden that is placed on patients in terms of getting timely care when the prior authorization process gets in the way. So this focus on prior authorization is, again, trying to help streamline the health system to make care easier to obtain and timely. So more to follow there. But again, this really lays down that basis. And so these requirements related to the interoperability rule have application to us as DHCS, as the Medicaid organization, and then also to all of our managed care plans. So that includes our Medi-Cal managed care plans that we contract with, our county behavioral health plans, which are considered PIPs and PAPs. So they fall under the managed care rule regulation, and this applies to them as well as our dental managed care. So this has a lot of touch points across our delivery systems in Medi-Cal, and especially as we're continuing to use more and more managed care, this then passes through as a requirement to DHCS and then to our plans. So we've talked a little bit about data exchange framework for California, CMS interoperability rule requirements, current and proposed, that those two are working together in order to help create the environment that allows us to move data. Now I'm going to shift gears and talk about the policy drivers that we have been implementing at DHCS as we try to drive these things forward, and what creates the requirements around why data needs to move securely, appropriately, and to support care delivery. So CalAIM, California Advancing and Innovating Medi-Cal, is a major initiative that we've been working on for several years and we'll be working on for several more years. There are a number of different components, and we're not going to talk about all of those components today, but just to highlight a few of the initiatives. There's the Population Health Management Initiative, and we'll talk a little bit more about that in just a minute. Enhanced care management, community supports, justice involved, and behavioral health delivery system transformation. All of these different components, in order for them to be successful, we have to have data exchange, and not just traditional data exchange in the healthcare arena, but then also incorporating data exchange across new provider types and organizations that have not historically billed or been Medi-Cal providers are now becoming Medi-Cal providers. And so it's not just the how do they bill and how do they participate, but then how do we also make sure appropriate data moves with the members, our Medi-Cal members, to make sure they're getting taken care of. So obviously everything has to be done in accordance with appropriate statutory requirements at both the federal and state level. But we do want to encourage and support data exchange as consistent with that. So diving in a little bit more, one of the things as we think about again, these requirements, we've incorporated notification requirements into some of these different programs. So in this context, using notification requirements broadly, often we think about notifications though as ADTs, so those admit, discharge, transfer notifications. In some cases, as in our population health management program, we have been explicit. So the population health management program began in January 2023. This is a requirement of our managed care plans. And in their contracts, we have language that says, to the extent that ADT feeds exist, Medi-Cal managed care plans are expected to use them to know when their members are admitted, discharged, or transferred. And then use that information as well in the context of risk stratification and segmentation of the populations they take care of. Also recognizing that ADT feeds may be a distinct data source as they think about their population needs assessments that they are required to do as well. As we move forward in developing our population health management service, we will look to incorporate ADTs in the future, although probably not in the first phases. So in the population health management program, we have been explicit about the use of ADTs to be used by our plans in order to support this care coordination. In our contracts, our Medi-Cal managed care contracts that will take effect in January 2024, we also include language around timely prior authorizations, transitional care, member and family consent, as well as, again, transfers of care. All of these things that are going to be supported by having appropriate data exchange. So leveraging the data exchange framework, leveraging the interoperability requirements, and then having these policy drivers that are part of our contractual requirements in terms of supporting our populations. Shifting gears to another part of CalAIM. So enhanced care management and community supports. So this area of CalAIM is definitely an area that is new. This is where we really have a significant number of providers, community-based organizations, and other entities, counties, and such that are now going to be able to be paid for providing services to our Medi-Cal members, which means they are now Medi-Cal providers, that they have to work on various kinds of claiming and invoicing that go to the managed care plan so they can submit that data to us via encounters. But also there's that local coordination and local data exchange. So again, information sharing is critical, whether it's in terms of developing a care plan, coordinating care, doing referrals, monitoring and reporting activities. Really important that we support data exchange. And so in that context, we've been developing various kinds of policy guides, data sharing, authorization guidance, and other components to help support providers, plans, counties in navigating this environment. Recognizing that bringing on these new provider types and new providers is a significant lift. We also have several programs that are putting out significant dollars to support that. So funding going out into the community through a couple of avenues that I'll highlight here. First is the incentive payment program. So this program runs through our managed care plans. The funds go to our managed care plans, and then the managed care plans have to report on various metrics to us in terms of how they're using those funds. But those metrics include things around, again, building sustainable provider capacity, delivery system infrastructure. So while that doesn't say explicitly connect to a health information exchange or health information organization, adopt a billing system, those things are tucked into this language, and we've tried to be more explicit about that in some of the other communication. Bridging silos across physical and behavioral health, again, trying to really look at that whole person view and decreasing the burden on our members, looking at health disparities, quality performance, and then, of course, uptake of community supports. So what we are calling community supports in the federal language, in terms of state Medicaid director letters and guidance that have come from CMS, there are two other terms that represent some of this. One is in lieu of services, ILOS, and the other is another fun term, health-related social needs, or HRSNs. So health-related social needs are things that are social needs that can be paid for by the Medicaid program because they're associated with health and health outcomes. And so again, the IPP program helps support building the infrastructures for this to occur. And then we also have the PATH program, providing access and transforming health. These funds are going not through the managed care plans, but directly to the communities in terms of going to community-based organizations, counties, other providers, in order to, again, support building this capacity and infrastructure to deliver services, including the enhanced care management community supports, but then also, for example, justice involved. We did get approval around our justice involved initiatives that will allow us to do that initiation of services 90 days prior to release, and then continuing that coordination as people move from jails and correctional facilities back into the community. So this effort is, again, putting millions and billions of dollars into the community to help build this capacity so we can provide these services. And then another opportunity in this space is the Behavioral Health Quality Improvement Program, which again, funding going specifically to county behavioral health to do similar kinds of activity around building capacity and making sure that there's the ability to use data, exchange data, and work with other providers to provide seamless care to our Medi-Cal members. Okay, shifting gears a little bit, I mentioned this before, but again, as part of our CalAIM initiative and as part of the state statutory requirements of AB 133 that provide an enabling authorization in California, enabling legislation, excuse me. So part of that had requirements for us to issue data sharing authorization guidance. And so we issued the first round last year. We have made a number of updates and added to it based on feedback from the community. And so I think we've probably just shut down public comment on this, and we'll be then finalizing it and having it available, the second version. But these are some of the components of the data sharing authorization guidance. So again, the goal to help navigate the environment, recognizing that there are some things that AB 133 did that helped limit certain state privacy laws to enable data sharing in the context of CalAIM specifically. But then also recognizing that there's a number of things, federal statutes in particular, we can't change. So the guidance is based to some extent on the model of the SHIG, the State Health Information Guidance that CDII, previously Cal OHI, released. in terms of having different scenarios, identifying the different laws that relate, and being clear around when consent is and is not required, and how to help navigate that environment. So that's available on our website. And then we also have just been wrapping up the Ask Me pilot, so Authorization to Share Confidential Medical Information pilot. This is a pilot in which we worked with 3 counties and organizations, so Santa Cruz and San Joaquin and San Diego, in the associated HIE-CIEs, Health Information Organization, Health Information Exchanges and Community Information Exchange in San Diego, to gather more information about this issue around consent, both the format of how we collect consent, how do we work with providers and patients, how does that get explained, what does it look like to have a consent management service, so can we collect that consent in a particular service that can be accessed by different entities, so that we don't have to keep asking individuals over and over again about what they consent to share. So we'll be collecting lessons learned and thinking about how that can inform us in terms of thinking about additional opportunities in the role for us as a state Medicaid agency, in terms of supporting consent for our members. So excited about having had that opportunity to work with, again, Santa Cruz Health Information Exchange and the Manifest MedX with San Joaquin and the San Diego Community Information Exchange. Really appreciate their partnership as we continue to learn and think about next steps. So I think that concludes kind of the formal slide deck presentation. Hopefully that helps tie some of these different pieces together. I realize I didn't necessarily cover everything. And then there's some additional slides in the deck that are for reference in case we end up finding that helpful to look at. But I can stop there and see if there's any questions.
This is terrific, Lynette. And one thing I heard when you presented at CAP was that CDII is really taking the leadership on putting the pieces and parts together and the guidance, and that you are there supporting through these tools, levers, and funding. And I can't emphasize that enough, that these are real dollars, real opportunities for organizations who need assistance, capacity building, and ability to be able to better their data sharing. This is where to look, especially if they're, of course, CalAIM and or serving Medi-Cal members. Just want to know if you can comment on that.
So I'll try to make sure I followed your question. So yes, correct. CDII is the lead for the data exchange framework. And so the data exchange framework, also part of AB 133. AB 133 was a really big statute that had a whole lot of things tucked into it. So, so at GHCS, sometimes by referring to AB 133, we're thinking particularly about CalAIM. When CDII says 133, they're thinking specifically about the data exchange framework. So all the same statute, lots of different subcomponents. So CDII, so Centers for Data Insight and Innovation, has the lead around the data exchange framework. They've been doing the different advisory groups, work groups, et cetera, in terms of developing the policies and procedures that will support that. As I'm sure you've been tracking, January 2023 was the time for folks to sign for the required signatories. Entities who are required signatories to sign the data exchange framework. January 2024, end of January, is the time for then those entities to start actually moving data. So the difference between signing versus the requirements around moving data. We have been working on being closely engaged because we do also have those CMS interoperability rules. So trying to make sure that all of those requirements that land in the policies and procedures for the data exchange framework are consistent with the CMS interoperability rules. We don't want to create confusion. Also making sure that things line up with TEFCA and the other work going on at the federal level, so that at the state we're consistent with and further advancing and not conflicting with the federal requirements. So CDII has been tracking very closely to that in terms of the again, the federal rules and incorporating that into the data exchange framework. So the data exchange framework has a number of required signatories, including managed care plans, including our Medi-Cal managed care plans. So we have incorporated that requirement that's in state law into our contracts with our Medi-Cal managed care plans. So we are tying together the requirements that are coming through under CDII to then have our contracts make sure we're reflecting, again, that state and federal law. So the contracts reflect the state law around the data exchange framework, the federal law around the CMS interoperability rule, to make sure we're getting at those consistency. And then working with our other partners at the state here, whether it's Department of Managed Healthcare or Cover California or others, in terms of connecting to try to make sure we're, again, driving at that consistency across the different pieces. So that's the kind of that technical infrastructure around what are the rules of the road, the legal sharing agreement, and then the policies and procedures for the technical how. In terms of exchange, that basis, again, building on high tech, building on all the work many of us have been doing for decades, depending on who you are, in California to help advance this infrastructure. Given that puts us in this place where we can really have this opportunity with CalAIM, while CalAIM focused on transforming the Medi-Cal program, working on improved consistency and trying to simplify where we can, because Medi-Cal is really complex. I've heard that, my colleagues describe that, nothing like trying to figure out rates, like payment rates, capitation rates, when we have different counties and each county may have different aid codes that are required or voluntary, et cetera. So part of CalAIM is trying to really get at improved consistency, simplifying the program to the extent possible, and doing it over a number of years. It's not happening overnight. It's not a one-time thing. We have different deadlines under CalAIM for all these different components, and recognizing that it really is changing the way we approach how we provide services to Medi-Cal means we're doing some of these new things like enhanced care management, community supports, justice involved. It needs infrastructure. So yes, we're putting money behind that through IPP, PATH, Behavioral Health Quality Improvement Program, other activities to really continue to drive forward using that infrastructure to drive forward and providing these services and support to our Medi-Cal members.
Awesome, thank you. I think it was a little bit of a leading question, but I appreciate the response. I'm looking at chat, there's lots of questions. I think several of them are connecting the dots with other state programs. One is around the 988 new service with crisis service delivery and mobile teams, and wondering how that might be connecting into the work that you're doing.
So yes, the department has lots of things going on. This particular slide deck talked about some of the CalAIM initiatives, but there's so much more, right? So there's the Children Youth Behavioral Health initiatives, the 988, the CalHope, all these different pieces around how to provide different kinds of support, and looking at these new kinds of services that we can pay for and fund. And so we're looking at how we put all those pieces together. So as part of our different programs, there's both new services. So I talked specifically about ECM and CS, but yes, mobile crisis, the different behavioral health services. There's new providers, so doulas, peer community health workers, peer support providers that we've been adding to our program. So we've got new providers, new services, new populations. And then one of the other things that you've seen happening for DHCS is there's a number of things that we've been asked to take on, and that we're excited to have the opportunity to support that are more cross-cutting. They're not just Medi-Cal. So for example, Children Youth Behavioral Health Initiative, the 988 hotline, one, it's not just DHCS, it's other departments within our agency, and it's not just Medi-Cal. So it's cross-cutting. So yes, we're continually looking at how we try to keep making the connections, because again, we don't want to make things more complicated. We're trying to keep things more streamlined. But it is, but these are new services and new activities. And so we're all working together to make those reality.
And I think we can forward these questions in the chat with you as well, but there are a few more about other programs like homelessness and another question around the population health management system. I'm just thinking that maybe we could ask you to come back to walk us through the population health management system, because it is such an important piece of the pie. And I'm just looking at our time. If you want to address that, and then maybe I just have like one more or two more small questions.
Sounds good. Yeah, maybe just a couple of minutes on some of those things. So on the homeless questions, so we are working with the team that does the homeless data information system in terms of how we can start to coordinate and share data in that context.
Great.
We actually have a new position that was just created, and I'm afraid I'm going to say it wrong, so I'm going to cheat and find it in writing before I say it. But Glenn Sang is our new policy advisor for homelessness and housing. That is at the department as part of our healthcare delivery systems. He literally started last week. So he'll be helping to do some of this coordination, as well as we think about, again, the homeless population, the incentive program. The homeless population is also one of our key populations of focus under enhanced care management and community supports. So obviously not just a DHCS effort, this is across a statewide effort in terms of how are we going to address homelessness more effectively. Again, participating in that conversation. Around sorry, I think I lost
the population health. We can.
Yeah, thank you. The population health management service. So one of the reasons I didn't talk a lot about the population health management service is that we're still in our development, very much kind of in our development stage. We have contracted with Gainwell, that was announced last December. We have been working with them in terms of what does this look like? How do we move forward? What kind of approach from a phased approach perspective? Again, not going to be a big bang, not going to be all at once. It will be something that we'll be working on over time. But the goal around the population health management service is really, again, the analytics around population health. And how do we do that consistently? And how do we have similar risk stratification and segmentation tiering across all of our plans, not having everybody do it differently? And with that service, we would be applying all these principles, not just to our managed care population, but also our fee-for-service population. So there will be lots more to come on the population health management service, but we're definitely still in those formative stages.
We are definitely an eager audience. So yes. Think of us as those milestones
we will
roll out.
Be back later, but that's probably gonna say give us a few months on that one.
And Robbie, can I take one more question?
Of course.
Okay.
Of course.
So Lynette, and this is a little self-serving because we're doing a paper, as you know, on consent and consent to share, and the Ask Me pilot, as it is wrapped up. Are you thinking about a next step there, or another round, or what's in store there, and when will we learn from the work there?
Yeah, so definitely taking lessons learned, working with those groups in terms of how that wraps up and such. I don't have specific next steps to share at this point in time, other than obviously want to take the lessons learned. I mean, one of the things that we've been doing a lot of thinking about, and one of the things we'd like to be informed from the pilots on is there a role, and if so, what is that role for us as the state Medicaid agency in this space around consent? Can we incorporate something within our Medicaid enterprise systems that we can support and fund, and how does all that fit together? So
super.
Definitely thinking about all those things. Don't have anything specific at this point in time, but those are some of the things that we'll be taking in terms of lessons learned and understanding, and then thinking about where we go next. So that would be another one for us to revisit maybe in a few months or so. Because it is, as we think about sort of the elephants in the room, every time we talk about health information exchange, digital identity, consent, those are two of the big ones.
Record locators. Yeah.
Definitely working around both of those and trying to figure out what's our specific role and how do we put these pieces together. And so we're working on those activities as well.
Super. Well, we'll follow up with you on that too.
Yeah.
Well, let's thank Lynette and put your questions again in the chat, and we can follow up, Lynette, with any additional questions. Thank you so much. You're welcome to stay as we review the rest of the agenda. But we welcome you at any time to come back. So
thank you. Yes, thank you so much.
Thank you. So Robbie, I will hand it off to you.
Awesome. Thanks, Timmy. And thanks so much, Dr. Scott. We really appreciate it and all the work. I think just to kick off with some DXF updates for folks. So since we last met, the PMP subcommittee met on June 27th. Really the crux of this meeting was spent on, several proposed policies and procedures and changes to existing ones. So a couple of highlights here for folks. There was a lot of really good weedy discussion, but just a couple highlights here for folks. Really one around the process for amending policies and procedures. It seems like there'll be a likely change to allow for 10 days of public comment for more administrative changes to the PMPs. So just to highlight that to folks is that CDII looks to be creating, mechanisms for both administrative changes versus more substantive ones when amending the policies and procedures and allowing for different durations of public comment. On privacy and security, a lot of discussion here around some of the proposals to apply certain HIPAA standards to non-covered entities that otherwise wouldn't be subject to some of them. There was, I think, a raised need for communications and education for those non-covered entities to really understand, what security policies might be required of them under the policy and procedure, especially since many of them, unless they've been a business associate and are familiar with some of those standards, just, they may need that education. Also too, just around, when a business associate agreement is and isn't necessary under federal law and per the DSA-2, just clarification for folks around, the need for a business associate agreement if you're say a vendor or working on behalf of a covered entity versus just being another data sharing partner who's receiving information who may not need a BAA. And, also too, thinking about how can we leverage the state health information guidance, which Dr. Scott mentioned, as well as other guidance documents to make sure that we, are educating folks about what's in the data sharing agreement through these other state guidances as well. Just a couple other things, the need for on like practical security practices. What are some tips and tricks or suggestions that the state can provide to folks who are signing the DSA as well? And then on real-time exchange, there was discussion about this PMP, which really gets to defining what is real-time exchange. Are there timeframes folks have to meet or reasonableness standards? I think there were some helpful suggestions to think about how to incorporate this policy and procedure into the existing technical requirements, policy and procedure, also into information blocking, policy and procedure, since they all kind of in many ways go hand in hand and work together. So just one, making sure that there are no inconsistencies, but two, thinking about how they might potentially be merged in some way. Any questions or any comments from folks about that meeting at all? Yes, and thank you, Mary Sarah. Helpful comment for non-HIPAA entities accessing data from non-HIPAA data. We need to also consider what data it is and how it's being accessed, e.g. view only, via portal, ingesting. Yeah, I think these are some of the issues that folks are starting to really kind of dig into when it comes to refining the policies and procedures and understanding kind of how to create streamlined rules for health and social services in this world in which we've got HIPAA that applies largely to healthcare organizations historically and not others. So I think next steps on these, we'll get, I think, an update at the next PMP meeting or IAC meeting in the coming month. in terms of further updates to policies and procedures, as well as new drafts of some of the proposals too. So we'll make sure to keep folks updated. Just a reminder for everyone, the data sharing agreement signatory grants, the portal's open. Also, round 2 has been amended such that both required signatories as well as non-required signatories can apply. So if you don't think your organization's on that mandated list, but you sign the DSA, you can get in an application for TA grants or QHIO onboarding grants. CDII is contracted with the Association of HIEs to help with QHIO onboarding grants. And PCG is helping with the TA grants. So there are folks that are there to help folks kind of navigate the process, walk you through how much money you might be eligible for. And there is significant funding available, $47 million total. So spread the word, get in your application if you think you might need some technical assistance or might be interested in joining a QHIO, which are still to come. But there are folks out there to help you. And just a couple upcoming milestones around the DXF. As we just mentioned, we're still anticipating the QHIO application. The draft was released this spring. We're still looking to see the final one, which it sounds like will be released hopefully in the coming week. So we'll keep our eyes peeled for that and let folks know once that is out. We'll include that in our newsletter and at a next meeting. And, hopefully too, our QHIOs get qualified soon, and we'll have a little more clarity on that process as well in terms of who those intermediaries are that folks will be able to join.
We heard that that's supposed to be coming out in the next 2 weeks. We'll see.
Yeah. The application.
Mm-hmm.
All right, another big update for folks on information blocking. Some of you probably saw this in health newsletters or in a news blast from HHS or ONC. So the Office of the Inspector General within Health and Human Services announced a final rule for penalties for information blocking. These are part of the 21st Century Cures Act passed at the end of the Obama administration, which included a whole host of things, called for the creation of TEFCA, called for information blocking rules to be promulgated. So this is really in response to the information blocking piece and creating an enforcement mechanism and really the sticks when it comes to information blocking. So these rules apply to developers of health IT, entities offering health IT, HIEs, health information networks. They do not apply to healthcare providers. They set certain priorities for investigation and for penalties. So it includes considerations like how long was information blocking going on? What was the relative level of harm that it may have been causing patient care? Penalties may be up to $1 million. And HHS is developing a separate provider disincentives rule that will apply to providers. So it looks like we'll likely see a proposed rule out later this fall from HHS that regards providers. And just to give you a little bit of a sense of where we're at with information blocking submissions. So while OIG was finalizing this rule, ONC, the Office of the National Coordinator, which promulgated the information blocking rules, has still been tracking information blocking claims and submissions since 2021. So what you can see on the right side is who's submitting these claims. Largely it's patients themselves. And you can also see too that the claims, so these are claims of information blocking, largely have been claimed against healthcare providers. And then you can see on here too, then health IT developers. In total, they've gotten over 764 submissions. And ONC thinks about 56 don't appear to be actual claims. But I think we'll see more of these investigations carried on now that we have the OIG final rule and kind of get clarity, especially as penalties get levied. What does information blocking look like in the field? What are instances where OIG will enforce the information blocking rules and the penalties? So I think more to come on this in terms of what enforcement really looks like and what those priorities look like on the ground. Any questions or comments on this at all?
Not for now, but I would just think that we should be collectively thinking about what we can do as Californians to be able to mirror and also bring it a little bit closer to home.
Yes, and thank you, Stephen, for this note. So yes, OIG won't be investigating claims that have already been submitted. It'll be after the final rule came out. Thank you for clarifying that. So these claims won't be investigated, but further submissions that are made to ONC will be investigated potentially by OIG, should they see the need to do so. All right, a couple state policy updates. So as I think many of you know, AB 1331 made it out of Senate Health Committee yesterday. This is Dr. Jim Wood's bill on the data exchange framework, passed yesterday 10-0 in Health Committee. Next, it'll go to appropriations. You know, big thanks to folks who have been signing on to our letters and offering up suggestions here in this forum on how to improve the underlying statute behind the data exchange framework. I think a lot of the large issues that remain, there are some amendments that will be forthcoming around shoring up some of the requirements for what the stakeholder advisory group needs to do around privacy and security within CDII. Some other amendments to the board and its authorities, and it looks like they'll be including a requirement that the board approve further changes to data sharing requirements under the DXF. Some of the amendments that went into print since we last met include a requirement that QHIOs be nonprofits is one of the main ones that came through. Cutting down those size of the board to 5 members with some ex officio ones. Also requiring signing the DSA as part of contracting with state agencies, including Covered California and Medi-Cal, amongst some others too. Any thoughts, comments, questions at all on AB 1331? Awesome. Well, we'll make sure to let folks know as we hear about further amendments to the bill and when it'll be heard in appropriations.
What's the timeline on that, Robbie?
We're on summer recess right now, so August, September.
Okay.
Yes, we're on a summer recess, so the legislature is taking a vacation right now. And just a couple other updates, because a lot of updates came through policy committees this week and in the other houses. So AB 254, we heard from Planned Parenthood advocates or affiliates of California on this bill, as well as the author's office, for making some changes to the CMIA. This passed Senate Health and has been re-referred to APROPS. AB 352, also from Assemblymember Bauer Cahan, this passed Senate Judiciary recently. We had a lot of discussion on this one around segmenting certain data related to sensitive services, including reproductive health. And then also AB 1011, this one regards closed loop referral systems and social care information. This passed Senate Judiciary as well. And a couple other highlights, SB 582. We heard a while ago from Senator Becker's office on this bill that would require CDII to develop some sort of standards for including EHR vendors in the DXF. Recent amendments to the bill also now require healthcare service plans and insurers to maintain certain APIs in addition to the ones that were put into law last year around the payer, or the provider API, as it's spelled out under the CMS rules. The amendments would also require them to maintain patient access, payer to payer API, and prior auth APIs once rules are finalized in federal regulations. And then as well, just as we've noted before, the trailer bill is no longer going forward on the DXF since we have AB 1331.
Hey, Robbie, quick question, Kelly with HealthNet. I just got a question about this via email on our internal folks on 582. So it seems like it's being characterized as it's aligning the new requirements for various APIs on plans are aligning it with the new federal requirements. Is that your take, or is it something new and extra here for California like we usually like to do?
Good question. I need to take a closer look at it too, but the language I believe says that they'd be in alignment once those rules are finalized. So I think a question is like, to what extent do the existing rules apply, right? So I think that's one question I have for the author's office is like the intent to also enforce existing rules, which I would think is the sponsor's intent. But not.
Yeah, well, I mean, I think their original intent was, to make sure that EHR vendors don't gouge providers as new and upcoming components of EHR are added. And I totally understand that concern. I just want to make sure we're not going above and beyond when it's something that's still in its formative stages, and that's not something that's being required by the feds. But I'll explore more, and if you can do the same, that would be great.
Yeah, definitely. I think on the API requirements, my understanding is that those would align with the federal CMS rules and take the ones that apply to the plans that fall under the CMS interop rule, especially like Medicare plans, apply those to state plans that otherwise might not be subject to the CMS interop rule. And I think with the piece around EHR vendors, previously the language said that it would require them to sign the, and now it's really kind of punting it to CDII and the stakeholder group to figure out what is the solution around EHR vendors, which I think aligns with what folks brought up here in our coalition meetings, that it seems like folks aren't sold on vendors need to sign the DSA necessarily, but is it requiring flow downs? Is it a separate DSA? What's the worst really of vendors too, because the definition is quite large and expansive in this bill. It goes beyond certified EHR technology. So I think there are a lot of questions that kind of have to get answered.
Well, I definitely appreciate the discussion here in this forum. And, I think in the months and years to come, as a lot of this is developed and finalized and implemented, I feel like there's going to be this push and pull similar to AB 1331. What do we put in statute? What do we have the group do? Like, where do we have the discussion? Did we have the discussion? Should we have further discussion? Like, it's very, very contentious, but I always appreciate the support of this group. So thank you.
Yeah, thanks, Kelly. And feel free to shoot any questions over as they come up too, because especially some of these bills have been changing a lot, and I think this bill especially has evolved quite a bit during this session as well. And we'll continue, I think, too, to have these discussions here. And as folks have thoughts on like, what is the proper venue to where these discussions need to take place? Is it something for a stakeholder group versus legislation? We can take those comments and then also think about how we ferret on comments or suggestions or position letters to the legislature or comment letters to CDII. Doug, I see you've got your hand raised.
Yeah, I have a question, Robbie. And we've been touching on this year. We didn't really touch on it much last year, and that was the integration of the EHR information from home health care, specifically the EOASIS. And I introduced you to a large vendor here in California, and there's two others that probably comprise 90% of the population that gets home health. So I want to know if we're going to, either think about putting together something for legislation or advisory committee or something that information is included, in addition to, I think we talked about it before, the information that the state has in with IHSS that kind of ties in with that too.
Yeah, I think we should let's definitely follow up on that. And I think that's a great, another great consideration too to CDII as they continue this work is, within the realm of EHR vendors and organizations that are signing or may sign, kind of thinking expansively about the vendors that are being utilized, the folks that are signing, what are their data sharing needs? What's this universe of vendors? Because I think this bill in particular, 582, is pretty expansive in its definition of an EHR vendor. So I think that's a great point to bring up to CDII in the event that they need to host these discussions. Is let's also think about the vendors that are being utilized by home health, SNFs.
It might even expand to the vendors that are doing like the RPM that I deal with and the telemedicine stuff with something else.
Yeah,
I think it's a great point. And one thing that we can do is think about how every fall we have a policy, kind of what's ahead for us for next year with our policy priorities. So Doug, we can work with you on thinking about how we pull that together and make sure that it's an area that we look at closer.
Sure, I'm happy to help.
Awesome. And Robbie, we're at the top of the hour. We want to just move through.
super quick. Some news items in our newsletter recently. Just a couple, an item here. If you'll be at the Association of Health Facilities conference next week, come find us. We'll be tabling there. CAF is one of our partners through the Data Exchange Framework Education Grant. I'll be on a panel with Andrea Fry from Hooper Lundy, and we'll also be joined by colleagues from Point Click Care, which is one of the major EHR vendors with skilled nursing facilities. We have an almost 2-hour session. We'll be coupling presentation with discussion around data sharing needs for skilled nursing facilities, what their questions and concerns about the data sharing agreement are. So should be a super good discussion. Please attend that session next Tuesday if you'll be there, and come find our booth as well. We'll be at the Sip and Stroll, I think it's called, on Monday night. So we'll have pins, buttons, and fact sheets for folks on the DSA. And there's also some other upcoming CDII meetings highlighted here too, for folks to tune into around grants, the IAC meeting later this month. And also ITEP is restarting its virtual regional work groups this month as well. So tune into those. And I think that's it, Timmy.
Awesome. Well, thank you. Thanks everyone for joining us today. Have a brilliant rest of the day. And we are going to join you all again 1st of August. You should have a calendar cancellation in 2 weeks. So enjoy your summer. We'll see you in August. Thanks.
Yeah, we'll have an email out to everyone about canceling our next meeting. So we'll see you next month.
Yes, going to Civitas. We will be there. We have a presentation on WIC with some of you. So we'll make sure we get together at Civitas.
Keep up the
All right.
great.
Thanks, everyone.
Thanks, everyone.